So Bismillahirrahmanirrahim. Assalamualaikum and a very good day. So this is about the central venous cannula complications. So we can divide the type of complications into two types, which is the immediate one and also the late complications. So example of immediate complications are like pneumothorax, arterial puncture, cardiac arrhythmia, the incorrect tip position, embolized fractured and of the guide wire or the catheter itself. While the late complication is the bloodstream related infection related to the central line itself. So oftentimes, the immediate one is the one that mostly being anticipated in ED, while the late complication might develop later on in ICU or in the ward. Or if it's something, if the patient being stranded in ED, then we might often overlook or tend to forget about this type of complications. So we go on with the first type, which is the immediate complications. The first one is pneumothorax. So this is the presence of air in the pleural space between lungs and the chest wall. It caused by the blind approach to assess the vein. So as you can see here, this is an example of pneumothorax as depicted by the clear lung margin from the black arrow. And the cause here, if you can see that when we want to assess the internal jugular vein, our needle tip might be poking the apex of the right lung, of the lung, sorry. So then, hence the reason why a patient can develop pneumothorax. Okay, this is especially when the needle was placed a bit too low towards the apex. And or if using ultrasound guidance, the risk is even higher with the out of plane approach rather than the in plane approach. So how to recognize it? So the moment we aspirated the syringe, so there is air or bubbles, patient desaturated or even develop hypotension if it's become a tension pneumothorax. And hence the management is to basically put a drainage to drain the pneumothorax. So how to prevent? So that's why we use ultrasound guidance and avoid the site with the highest risk. So which are the site with the highest risk? So we know we have subclavian cannulation, internal jugular or femoral vein, and it has been shown that the one with the subclavian approach has a higher pneumothorax risk. So for the second complication, which is the arterial puncture, it causes again blind insertion, and as we all know, anatomically, most of the arterial is side by side with the vein. How to recognize it? So it's usually pulsatile, bright red in color, but this color might not be that reliable, especially in patients who are critically ill when the oxygenation is bad. So hence, it might appear as dark as vein. So how to manage it? So we must withdraw the needle and compress. And sometimes even in large hematomas, it might require a surgical exploration. So this is the list that we want to anticipate. So how to prevent? Perhaps we have to ensure that the patient has an adequate coagulation status. And again, the usage of ultrasound guidance so that we are poking the vein instead of the artery. The next complications is the embolized fractured catheter or guide wire. So what can cause this? Based on the Saldinger technique, so this is a technique where we use the guide wire to guide our catheter. So it's a good technique that has been introduced to assist central venous cannulation, but there is a risk that the one who perform might dislodge the guide wire in or forget to remove the guide wire during insertion. So how to recognize it? If there is a placement, there is a misplacement or there is a fractured catheter and or guide wire. So externally, there is a leakage of blood or fluids during flushing, and internally, patient may complain of pain. There is a redness or swelling on flushing or during drug administration. And even for the performer who basically forgot to remove the guide wire, it can be an incidental finding of guide wire when they do a check X-ray. So the removal is actually through interventional radiology. Okay, so this is how to prevent it. Okay, that's why part of the set is actually the small artery forceps is used to clip or fix the non-J end of the guide wire during our introduction of a dilator and while sliding our CVC into the vein. This is a very important step during CVC insertion. The next complication that patient can develop is a cardiac arrhythmia. So basically, because we are directing through the venous system and then to the right atrium, towards the right atrium, so perhaps sometimes it can be too deep that there is causing a direct stimulation of the myocardium by the guide wire or the catheter itself. So this can affect both the arterial and the ventricular system. Hence, the reason why the patient should be on cardiac monitor. And if it's happened, then usually we know we are like going too deep. So we should basically pull it a bit, and usually it's spontaneously resolved. So as a precaution, we should take some CVS, know some background cardiovascular history of the patients. And the most important step is actually to insert it with the average insertion depth. The next complication is the incorrect positioning. So there is some relation with the previous complication. So how do we know that it is an incorrect one? Basically, when the tip is actually in the venous system, but not in the right atrium, SVC or IVC. Or if the distal section of the tip is not parallel with the vein wall, meaning it's like abutting the wall. So this is incorrect. Or the line itself being kinked within the body. And of course, if the catheter lies outside of the venous system. So how do we recognize this? So during flushing, we feel like it's a bit discomfort for the patient, or we feel like it is quite tight to either flush or withdraw blood. So how to manage it? We need to reposition, even replace or remove it that's needed. And how to prevent it? We need to insert it with average insertion depth. So this is an example of the X-ray of a check X-ray with correct tip position, where the tip is just or at the level of the carina. So this is carina. So it is at or just below the level of the carina. Okay. All right. So this is correlating with the region just upper the right atrium. So maknanya kalau dekat SVC tu is the lower part of the SVC before entering the right atrium. Okay, so in term of positioning, so anatomically, okay, so kalau kita tengok sini, okay, kita sekarang nak aim kat mana correct tip position kan, okay, based on the X-ray tadi tu. So katalah kita ada 3 zone ni, zone A, zone B, zone C. Okay. Zone A dengan B ni adalah SVC lah basically. So A ni is the lower border, the lower part of the SVC. Zone B is the upper part of the SVC. And zone C ni is kalau kita directkan daripada left internal jugular, maknanya dekat brachiocephalic before they enter the SVC. So among these 3 zones, okay, the most ideal one is actually zone A. Okay, so this is in the SVC. So kenapa zone A? Okay, so ada beberapa, there are few factors lah why this is the ideal position or tip position. Is because this is the venous site with the largest diameter here. So just before the right atrium. Okay, the diameter is important because we don't want it to like land it in zone C, because this is quite small, the diameter. because the drug that we give, actually it will basically first dia akan hit the venous wall. So if it's like a very highly concentrated drug, for example, kalau if we use the one with the smaller diameter, then it may in long term damage the venous wall. And another one is because the diameter is quite big here, so usually the tip position is, it can be parallel lah, not hitting the venous wall. So again, that will prevent the damage of the venous wall. Okay. If it's in zone C, okay, then there is a risk that it's not like it can king ataupun the dilution, the medication that we serve actually is directly hitting the wall instead of entering the vessels, right? So zone A. So here's some explanation that I mentioned earlier. And yes, zone A is actually our aim for the tip of the catheter. So this is, kalau for the right side is like quite direct. So for the left side insertion of the interjugular vein, it should be deeper so that it reach the zone A. Okay, then we finish with the immediate complications. Let's move on to the late complication, which is the central line associated bloodstream infection. So this is defined as the infection related to catheter line. It depends on multiple factors, especially if patient is already immunocompromised and the duration and so on. But what is important that can be done in ED for the prevention is in terms of how we perform it, which is the degree of aseptic technique. So this is something that we can improvise ataupun something that we can do in ED itself. Right. So the type of infection can be divided into the main group. It can be localized. So there's a localized erythema, swelling, or edema, and systemic. So patient can develop sepsis without any other source of infection. So most of the time, the organism is because of coagulase negative staphylococci. And how do the microorganism go through? Okay, it can be because of the infusate itself. For example, the fluid or medication that been given, mungkin ada yang expired. The manufacturing itself, and then the catheter hub itself become contaminated, and the skin organism. So that's why the healthcare workers handling the catheter should be fully sterile, kena pakai the barrier, the glove, the sterile glove and so on to prevent this to happen. Okay, as for the prevention in terms of site, okay, if we were to compare, so we have the site either internal jugular, subclavian or femoral. So the highest risk of infection is the infemoral lah. So this is quite obvious because it's a perineal area, groin. So it's quite, prone to infection. Okay, so when we want to decide about which side of central line we should insert, of course, it varies among patients. We have to take into consideration few factors. Okay, for example, if we talk about prevention of infection, of course, femoral is not the best side. Okay, but when we talk about, for example, we have a patient with decompensated dengue shock that, for example, refractory hypotension and need to start inotrope because of, for example, superimposed vasoplegic shock. So you want to start vasopresses. So or you want to infuse blood because of poor line access. The peripheral line is having a very poor access. Then for this type of patient, maybe infection is not number one, but saving the life is more priority. And perhaps the site you still choose femoral instead of like interjugular or subclavian, because for someone with a low platelet or with coagulopathy, if you develop hematoma on those sites, the interjugular and subclavian is very hard to compress. And it cause edema, it can cause swelling that affecting the upper airway, for example. So that's why when we say about the site of insertion, it varies between individuals. when we talk about prevention of infection itself, yes, femoral has the highest risk among the others. Okay, as for the materials, the disinfectant that is being proposed, that has shown to actually be effective, is actually the 2% chlorhexidine in 70% alcohol preparation. So this is actually even more effective than the 10% povidone iodine. Unless our patient is allergic to chlorhexidine, then we can switch to the povidone iodine preparation. So, and before the usage of the access port, the port or the hub should be wiped with 2% chlorhexidine for 30 seconds and allowed dry prior to access. In terms of dressings, transparent dressings will allow a direct observation whether there is development of erythema or swelling at the site, and the site should be inspected at least on daily basis. For healthcare workers, of course, it's compulsory for hand wash and rub and full barrier precaution while handling the central cannula. And this is our EDHKL's CVC checklist. So this checklist is very useful to assist us because it has summarized the steps and also the equipments needed. Okay, this is available in resource. So this is supposed to assist us so that kita tak ada miss the steps and the equipments to being prepared accordingly. Okay, so we have the patient's name, the details of the patients, the details about who are performing the CVL, and the indication and the sites. And these are the critical steps. So critical steps is the same like the CVC videos that you're gonna watch. Okay, and these are the list of equipment. So I think this is quite useful because if you sometimes if you don't, especially when you don't do it quite frequently, you might forget certain stuff, and so tak adalah macam halfway buat tu tiba-tiba terlupa kena ambil barang, panggil orang, macam it's very tak organised kan. So this is dah compile siap-siap, so you can just take the list, pastikan semua ada, then baru you perform kan. It's very useful. So this is in our research. Okay, so this is for the monitoring for our staff nurses and also MAs. Okay, so that's all about the presentation of the CVC complication. Thank you.